Hi, everybody, and welcome to the third CPH review session, actually covering our second domain. My name is Gillian Plant. I'm the Marketing Director at the National Board of Public Health Examiners. I'm here to monitor the chat and Q&A, so you can use that throughout the entire presentation. If you have a question specifically for the presenter, be sure to put that in the Q&A, and we'll hopefully be able to get to those at the end if we have some time. And the chat itself is open for you all to interact with your fellow attendees. Today's topic is data analysis and informatics, and it's presented by Dr. Saida Sharapova. Dr. Sharapova is an epidemiologist with a clinical medical background and 10 plus years of experience working as a researcher, analyst, epidemiologist, trainer, writer, and physician. Her career began as a neonatal intensive care and as a pediatric neurologist. Soon she realized that people need systems, policies, external motivation, and default choices to be healthy. She found her passion in public health and her talent in data analytics. Saida's work has included strategic planning of a long-term evidence-based program to reduce infant mortality in Georgia that awarded $2.5 million in grants to 16 organizations. She has been first author or co-author of 14 peer-reviewed publications and contributed to 2 U.S. Surgeon General reports. One publication she co-authored, entitled Tobacco Product Use Among Middle and High School Students in the United States 2011 through 17, became the most influential publication by the CDC in June 2018, reaching an audience of nearly 600 million. Saida's current research interests lie in epidemiology of neurological conditions, and she is supporting CDC work on the National Neurological Conditions Surveillance System. And with that, I'd like to turn over control to Dr. Sharapova.
Thank you, Gillian.
Thank you.
And welcome, everybody. Good morning, good afternoon, good evening, whenever you are. I hope you are ready for a very intense presentation. We have a lot of information to cover, and I'm looking forward to sharing everything that I have to share with you today. Today's topic is data analysis and informatics. As Gillian already said, I started my career as a physician, as a pediatric neurologist, and I moved to United States in 2006. And since I moved to the States, I had my interest in public health. So I did my master's with Georgia State University, and I sat for CPH exam in 2013. Why did I choose CPH? 3 main reasons. First, to challenge myself. Second, to make myself more marketable. And third, to have some additional motivation to stay current with my field and continue growing as a professional. My current areas of expertise include children's health, infant mortality, tobacco research, tobacco control. Currently, I'm working with the myasthenia gravis registry that follows natural real-world evidence of treatment for myasthenia gravis. And in the past, I also worked with surveillance systems for Parkinson's disease and multiple sclerosis with CDC. My day-to-day work includes analyzing data, and my favorite software for that is SAS. I'm also well-versed in complex survey analysis and now in real-world evidence. So I hope this expertise will help me, and my diverse work experience will help me to explain some concepts in more plain language today, and focus on the concepts that a lot of people get confused with. hopefully making them less confusing and more clear. The game plan for today is to provide you with some high-yield review. The topics that I would like to cover are so many that it's impossible to cover them all in 2 hours. But a lot of them made it into the slides, and this slide deck will be shared with you for your review in the future. This is a very high dense review material for you. Objective 2 is to focus more on the areas where there is, where I see confusion among people, especially among people who do not deal with data or analytics on day-to-day basis. And objective 3 is to practice some CPH questions that are included in CPH practice exam. Data analysis and informatics is a renamed domain on CPH exam that, and you just need to quickly review something. Here are some tips for successful certification for passing the exam that applies not only to this domain, but exam overall. I would like to spend a little time on that. First of all, and I already said this practice exams on NBPHE CPH resource page. When you're in exam, read questions and response options carefully. Do not jump to conclusions. Read the question first, understand it, try to predict the answer as you read the question, and then read the answer options and see if what you predicted matches one of them. There is only one correct response option, and all questions are formed in a positive structure. It means you do not need to think about things that do not belong. Right? It will always be one response that fits. Do not remember, cannot figure out the answer, just guess. There is no penalty for incorrect answers, but only answers with responses, recorded responses, are counted toward your score. So rather than getting a score of 0, it's better to get a chance, 25% chance of guessing correctly. Now, to resist adding some tips for, especially for non-data people out there, for their day-to-day success in public health. Being an epidemiologist, I believe it's very important when you deal with any data, any analytics, any report, take time to get to know the data behind those. If you have access to a statistician in your team, befriend that person, talk to them often, ask questions. And especially important, be aware that there are things out there that you do not know that you do not know. That's the dangerous area where we all lose our competence and can make mistakes. So asking a lot of questions is always a good idea. Remember, math and data science go hand to hand. And now we are at the beginning of the first content slide, introducing some basic concepts. And we start with the definition of population. Population will be the largest possible number of entities, in our case, people, for which we have interest. And let's always remember that all of these metrics are usually connected with certain time period, like normally it's annual report. And populations are defined by the sphere of interest, and population metrics, like whatever we measure about this population, we call parameters. The populations are usually big, and we don't always have access to measure exactly the entire population to know what we want to know about them. So normally in epidemiology and statistics, like in data, we take a sample. We take a part of this population and measure them because it's more manageable. And the parameter, metrics of the sample we call statistics, just to distinguish it from the parameter of population. And we always believe that the statistics that we measure approximates the parameter of the entire population. There is not so much difference between biostatistics and epidemiology. Both apply research methods to human population, and biostats is like more wider science, and epidemiology focuses more on health-related events and statistics. We distinguish two types of statistics, descriptive and inferential. Variable is something, any data point that we use in statistics, and it can assume different values. And we manipulate variables and calculate variables to get to conclusions, to get to know what we want to know. We separate these variables or numerical data into two major types, categorical and continuous. And the main difference is that the categorical variables represent any quality or trait, anything. It can be measurable or unmeasurable, whereas continuous is something that is normally very measurable and represent how much or how many of something a subject has, like quantity. Examples of categorical data would be hair color, type of exercise, degree, educational degree, and examples of continuous data would be height, weight, age, number of hours slept at night, or blood pressure. This is a very useful thinking algorithm to define different types of data. So if data represents qualities, traits, or groups, it's most likely categorical. If it has only two possible values. It's dichotomous. If it has more than two, and it doesn't matter in what order we put those values. For example, it can be different types of dog breed. That would be nominal data. If there is certain order we can put these values in, for example, from smallest to largest or from lowest to highest, that would be ordinal data. For example, educational level, high school, college, postgraduate degree, right? It has some order to them, but we do not necessarily measure the difference between these categories. They can be, even if they are measurable, like blood pressure, we can divide into normal and pre-hypertension, stage 1 hypertension, and so on. But we don't necessarily calculate the difference between those numbers. Whereas with continuous data, we can always do some calculations with those. And we separate continuous data into interval and ratio. And ratio data is the one that has a true zero into it. It means there can be absence of that quality or quantity that we're measuring. And ratio, you can memorize it better because it has O in it. It means O means it contains zero, whereas interval doesn't have O. It means it doesn't have true zero, and also it looks like there is a certain amount of value of the variable between certain checks on it, like say, oftenly used example is the temperature, right? We separate degree, we can say it's like 10 degrees, 20 degrees. It even has a zero, but the zero on, for example, centigrade scale does not mean that it's absence of temperature, it just means it's very cold, right? And we cannot truly say that like 30 degrees are twice as high as 15 degrees. Whereas if we say like 30 apples are twice as much as 15 apples, and we can run out of apples and have no apples at all. So in the amount of apples, number of apples would be ratio data, and centigrades, like temperature scale, would be example of interval data. So I'm going to skip all these slides and let you review them at your own pace. Just stopping here to say that when we summarize data, we look at why we need to know all these qualities of different data types, because it helps us to use correct methods for summarizing, visualizing, and analyzing this data. For example, we have for categorical data, we usually use frequencies, relative frequencies, cumulative frequencies, and visualize them as bar charts or histograms or pie charts, right? Whereas for continuous data, we usually use summary measures such as mean, median, quartiles, standard deviation, range, and we depict this data as box and whisker plots or histograms. So just quick reminders, mean would be an average value, median would be a value that sits in the middle, of the numbers, if we arrange all the numbers from smallest to biggest. Mode is the value that we see most often in the data collection, and range would be the space between the lowest and the highest value. And now we came to our first practice question, and I believe we have poll that we can do with that. Gillian, how do we do the poll?
Let me pull those up right now. Do you see that? There we go, great.
Yeah, we can see that.
Great.
So times observed for completing a sorting task are scored in terms of order to finish. This is example of continuous data, interval data, nominal data, or ordinal data.
And I'll give you about 5 more seconds to answer. 5, 4, 3, 2, 1.
And most of you are correct. This is ordinal data. And I understand why some, like about 10% of people said it was continuous or interval or even nominal. This is not like directly stated, but if try to imagine this data, like how it would look like. And you can see that there were measured times, right? So we already start thinking, okay, measured times, it's most likely continuous data. However, it's these times are scored in terms of order to finish. It means that the measured amount of times were assigned some score, right? Means they were categorized into some groups. And in order to finish, it means that we do not really analyze the times here, but we are looking at the categories, certain category scores in order of finish. Most likely it will be finished within time, finished beyond time, or took like really long time to finish. So that already makes it a little different, right? So correct answer is actually ordinal data, because in order to finish is implies we have categories that were structured in some order, right? And this indeed is the correct response in this case. Now let's move on to probability. So simply put, probability is a proportion that is the number of observations of interest over the total number of observations. It means of like whatever, how many units we observe, how many of these units, out of these units, have the trait or characteristics that we are interested in. And this is a proportion as a whole, of a whole. So it will have values between 0 and 1, or between, it can be expressed as a percentage between 0 and 100%. These are the three types of sampling from the population. It's not the only three types that are available. There are so many more sampling strategies, but these are the most frequently used, and we need to understand difference between them. Simple random sample is the one that is assumed for most of the statistical methods and analytical methods. From the practical standpoint, it's the most expensive because we need to have access for the entire population from which we will randomly select individuals. And then we need to have access to all of these individuals. Hopefully they all will participate in our research and provide their information. And completely randomly, we will select, means completely random means that anybody in this population has an equal chance to be selected, right? So first of all, we have access to the entire population. We can randomly select any individual from that population, and we can get information from all of these subjects. So you can see already how it can get expensive in real world to get information like that. So we have better approaches like systematic and stratified samples, which eases access to information. Systematic sample is when we ahead of time define the skipping point for selection of individuals. For example, we have a number of houses on the street, and we decide that we will survey every 7th house, right? So we use some random methods. Some people even like rotate a bottle to point at the house, and we randomly select the first subject, and then we use our skipping pattern to go from this first house to all the houses we intend to survey, or all the units we intend to observe. With stratified sample, it's a little different. We need to first define strata, which must be independent. It must be some characteristics that makes those populations that belong to one strata for surely never belong to another strata. It can be different schools, it can be different cities, it can be gender, it can be different grades within one school. And then within each strata, we select individuals at random. You can see that it is going to be a little bit simpler and easier than going with a simple random sample. But then when analyzing data like that, we need to apply certain weights and certain analytical variables to it, so we can calculate statistics that are representable of the entire population. So these two, systematic and stratified samples, are examples of complex survey systems that need certain software to be analyzed properly. When we have a bunch of numbers that representing some statistics and put them all together on a graph, right? We can see that these numbers create certain patterns. And these patterns we call distribution. We define binomial distribution. It's when we only have two possible values for data. So on a graph, it will be like some points, like a gender, say, female, male, we will have data clustered as females and data clustered as male. We can have data in a shape of a bell curve, and this is normal or Gaussian distribution. And it is most used distribution in statistics and epidemiology. Why? Because it's what we mostly observe in nature, especially given large enough amount of data. We can expect that most of it will create this bell curve and respond, like meet our assumptions about it. And we also have a Poisson distribution, which we use to analyze data that are counts mostly. So for binomial distribution, we have 3 assumptions. And assumptions is something very important to remember about data analytics, because we assume that data fits certain criteria before we can analyze it in a certain way. If the data is not fitting our assumptions, we need to contact statistician and make sure that we apply correct methods for correct type of data we have. So with binomial distribution, our 3 assumptions are that we only have 2 possible outcomes for each trial, that probability associated with that outcome is the same for all trials, and that the outcomes of each of the trial are independent of one another. For normal distribution, we assume that the distribution is symmetric and we have enough data points to really have this bell curve. And it doesn't have to be like completely symmetric. We will talk about, you will read on your own about skewness and different like flatter and taller bell shapes and having outliers. But normally, like which means in most cases, we will see this classical bell curve, which will have about 3 standard deviations between its within the 99% of the data that it contains. It will be characterized by mean or average and standard deviation, or the difference values that are different from the mean, right? Some scientists also distinguish a paranormal distribution, but we do not have time to talk on that today. What is important for us to understand today is the central limit theorem. What it means? It means that for population with a mean, certain mean and certain standard deviation, if we take a large enough amount of simple random samples from this amount of population data that we have, and we put together the means and standard deviations for these different samples that we took, they will have the normal distribution. And this is the more graphical representation of central limit theorem, which shows that the distribution of each sample can be different. It can be Poisson, it can be binomial, it can be bell curve, normal. But when we put all of them together, if we have a lot of them, like enough of them, all this sample means, the means of each sample will have this normal distribution. Why is it important? It explains why so many natural phenomena follow a normal distribution. It also allows us to make generalization. It means that we can apply what we observe in the sample to the entire population with a level of certainty. But the data must meet assumption. The samples must be randomly selected. They must be independent. They cannot influence each other. And they should be large enough. In statistics and epidemiology, we normally go with the number, golden number of 30. So if we have 30 values, we assume they have normal distribution and meet this assumption. Here we have some common measures of frequency. And I want you to understand the difference between rate and ratio or proportion. In epidemiology, the rate is when we take some metrics and put it into numerator. And for denominator, we have the entire population, the population that we measure. Whereas for proportion or ratio, we can use anything. It doesn't have to be the population. It can be two metrics divided by each other. It can be proportion of disease, for example, out of all diseases, right? But it will be rate if we take proportion of disease, number of diseases observed in the population of like Atlanta city in 2024, for example. And we came to our second practice question. Gillian, can we have a poll, please, for this one? Which of the following relationships most accurately describes a positively skewed distribution of human body weight measurements? Just a quick reminder, positively skewed, it means that the bell curve will be leaning to the right. It will have to the bigger, larger values. It will have like steeper slope.
I'll give that just a couple more seconds. And ending the poll.
And 60% of you are correct. The mean is greater than the median.
And it's a nice shape of a bell curve.
And those who responded differently, I want to explain that skewness is a reflection of how the mean and median work with each other, right? Normally, if we have large enough data and we want the symmetrical bell curve, median will be very close to the mean. Skewness is when median or the middle value is shifting and is different from mean, which brings the shape of bell curve to lean right or lean left, right? So when the median is smaller than mean, it means the average is bigger than the middle number, we have positive skewness. And when we have a mean that is smaller than median, the bell curve will be leaning the other way around, and we have a negative skewness. Now we're getting into inferential statistics. And this is when we use methods to analyze data and then apply what we see in the sample to the population. Like we make inferences about the bigger population based on what we observe in the sample. For example, we observe customers who bought a left shoe and we infer that they also bought a right shoe. Confidence intervals is a measure in inferential statistics that often gets people confused. For example, we have, in most approaches, we have values and we have confidence intervals, for example, printed in a paper. And we see the statement that the statistical significance was assumed if the confidence interval did not overlap. What it means, if we measured the characteristics, for example, between males and females, and the confidence, and we put them on the graph as a boxy whisker plot. And let me go to the next slide, maybe it will make it easier. So we plot values, and this is how we depict confidence intervals. And if we see the confidence intervals do not overlap, like for these two, what you call them, column values, groups, that means that difference between these groups that we observe and measure is statistically significant. For this confidence interval and this confidence interval, we see that they kind of overlap. If we calculate all the proper statistical tests, we can be sure that there will be no difference between these two groups. However, it's not necessarily true if, like, we see slightly overlapping confidence intervals, because the statistical test, proper tests, when calculated, they can show that these samples are still significantly different from each other. It's just that not always we have opportunity or data good enough that we can calculate the proper statistics. So this approach of non-overlapping confidence intervals is the simplest and most scientifically safe. And if we want confidence intervals to be not too wide. So you see this guy has a very wide confidence interval, which is almost as big as the range of the values we measure for this group. So this confidence interval does not give us much confidence that we measured it. The value that we measured for this group really fits into the population range of values that we expect to see if we were able to measure it in population. Let's go back to this slide that shows that confidence intervals are usually measured at 95% level, which means that we assign alpha level or type 1 error level at 0.05. And when we calculate statistical tests and have p-values that are smaller than this alpha level, we can say that we have statistically significant result. And what 95 means? It means that if we measure this parameter of the population, we are 95% sure that this parameter will be within the lower level and the higher level of the confidence interval that we calculated for the sample. Which brings us to hypothesis testing. Hypothesis testing is an approach where we set up two statements that completely exclude each other. And we do it usually before our even collection of data. And we specify some measures that will allow us to accept one of these statements based on the results of our study. So we start with research hypothesis or alternative hypothesis. This is approximately the research question of interest. And it fits the formula of saying, so we measure statistics, we measure something between, let's say, two groups. And if we compare these two groups, there will be difference. And this difference will be statistically significant. And we can say so that there is an effect that we actually want to observe. It can be like difference in knowledge pre and post test. It can be difference in blood pressure between males and females. It can be difference in grades between children of the same grade in like city school and a rural school, for example. And we also come with a null hypothesis, which is an opposite of research hypothesis, and basically says that between these two groups of interest, there is no difference. And like rural children and city children in 7th grade will have the same range of scores on MAP testing in spring 2024, for example. And that's where p-values and alpha come in. When we calculate the p-value based on certain analytical methods and statistical tests are properly applied to the proper type of data that we have that meets all the assumptions that it must meet. So p-value that we get as a result of this analysis shows us that if the null hypothesis is true, meaning that if in the real world there is no difference between the two groups that we are measuring, how much is the probability of seeing the result that we're seeing occurring there? Meaning that result occurred there by chance only and not as a result of our risk factor influencing the result or our intervention influencing the result. So for example, let's say the p-value that we obtained is 0.02. It means that if there is no difference between rural children and city children, and our result is affected by chance alone, there are in 2% of measurements and 2% of children, there will be truly no difference. We will have the same, these MAP scores that we see them among them. This is very low, right? This is a very low chance. And it's below the commonly used alpha level, which is 0.05, which we decided to use for this research. So because it's so low, lower than alpha, we can confidently reject the null hypothesis. We can confidently say that it's not true that there is no difference between these two groups of children. And mind that we did not prove that there is a difference, but we rejected the null hypothesis. And therefore, we assume that the research hypothesis is correct. Because there is only two, right? It's one on another. So if we rejected the null, the research should be correct. This is how this works. So this table shows us 4 possible decisions based on p-values. Because we use sample and we just infer that this sample truly reflects what's going on in the entire population, we have room for mistake. And we can make 2 types of mistakes here, or errors. Type 1 error, or alpha, is when we reject the null hypothesis, right? We find that p-value is small, it's smaller than alpha, and we reject the null hypothesis and accept the research hypothesis, when in fact the null hypothesis is true. There was something wrong with our measurements or with our calculations, and this p-value is wrong. So this is type 1 error. And we are claiming that there is an effect, that our treatment made a difference, our education made city kids smarter. When exactly in life, there is no difference between these groups. And this is what we call type 1 error, or alpha. And the way to remember it is it's false positive result, right? And letter P has 1 vertical line, which is like Roman numeral 1, or type 1 error. So it's false positive. Type 2 error, or beta, is overlooking an effect that is really existing and accepting null hypothesis. We observed p-value that was large. We don't know why. It can be that we measured incorrectly, our instrument measurement, our tool was incorrect, there was some bias, there was something that in the data that we used the wrong analytical method, and the p-value is big, and we say that the null hypothesis is, we do not reject it, we fail to reject it. And we say that there is no effect and there is no difference between the two groups that we're observing, when actually the effect is there. We did make the difference with educating city kids, for example. And so this is a false negative result that we're getting. And if we look at the capital N, it has 2 vertical lines, which corresponds with Roman numeral 2, right? So false negative is type 2 error. This is just a way to memorize the difference between 2. I hope it helps. So alpha level is the threshold that we use to determine whether or not the p-value is set low enough in order to truly reject the null hypothesis. So balance here that we look for is to set it low enough so we increase our chances of finding the true effect, but we need to have like really strong data, a lot of data, good quality data. Mostly it has to do with sample size and power, that data can reliably respond to our question and support our analytical method, and give us confidence that this p-value that we are observing at this alpha level is what is truly going on and is measured correctly. The smaller the alpha level, the more we're trying to protect the null hypothesis. So increasing the alpha level of the test increases the chances that we can find a significant test result, which is good, right? We want to prove that our intervention was significant and made a difference. But the larger we set this alpha, the more chances that we make this type 1 error and reject the null hypothesis when it's actually true, and claim the effect that is not existing. Okay, so Gillian, can we please have this poll? Thank you. The probability associated with specific results when the null hypothesis is true is expressed by what?
Give about 15 more seconds. Five more seconds. And ending.
Yes, this is a p-value. So we already talked that p-value is a probability of seeing specific result when we assume that the null hypothesis is true, right? Everything else is clearly not the probability, right? It's distribution, it's an error, and it's conditional independence. So p-value is an only measure of probability among the four. So this is the correct answer. Next question. This is very tricky question. But let me tell you, you do not need to remember the formula for confidence intervals in order to be able to answer this question.
Give another 15 seconds. And 5 seconds. And closing.
Okay, let me tell you how to approach a question like that. Let's just think, read through the question and think. So we have a sample of about 1,000, right? And 55% of them have a certain metrics. They responded a certain way. And if we have 4,000 people, like 4 times more, how will it affect the confidence interval? Remember, the smaller the confidence interval, the better for us, right? It's a more precise measurement. And remember that the bigger the sample size is better too, right? So better, more people we have, smaller confidence interval we'll have. right? So we can eliminate this C and D already. Right now, we need to decide by how much will this confidence interval length decrease. And here, if we vaguely remember statistics that we took during our MPH or PhD courses, even during our high school math courses, maybe for some of us, we can remember that there was some square rooting involved. And if square rooting is involved, that the factor of 4 is most likely to be reduced to a factor of 2. So we can guess. I guess that B would be correct answer here. Right? So we already have 50% chance of answering correctly on this question. But if we do our review for the exam and we did memorize all the formulas and we are remembering them, then we indeed see that there is a square root and the sample is under there. So it will be decreasing of the result, and square rooting and the factor between 4,000 and 1,000 is 4. So square root of 4 will give a factor of 2. So if we use this formula for the sample of 1,000 and the same formula for the sample with 4,000, what different result we can get? We will decrease the result by 2, which brings us confidently to the correct response of B. Okay, now I propose we have a 5-minute break, refill your drink, use the bathroom, and we'll see you at 3:12. Thank you. Welcome back. Commonly used statistical tests. This is a schematic that I really like. It shows that depending on our research question and the dependent variable type, continuous or categorical, and the number and type of independent variables. So dependent variable being the outcome that we are measuring, and independent variables being the, sorry about that, risk factors, protective factors, other influencing factors, our intervention, whatever we are applying to analyze the effect. And depending on this number and type of those independent variables, what statistical methods we are most likely to apply. This is very simplified. There are more methods, of course, but these are most commonly used methods. And one of them is chi-square test of independence. It tests to see whether two categorical or nominal variables, meaning they're not continuous, are independent, meaning related to each other or not. And it can be used if you only have a table of values that shows frequency count. Typically, we want more than 5 in each table cell that we have. And it does require that the data values come from a simple random sample. What to do if we don't have a simple random sample? We apply proper weights and use different statistics to get to the same results. Like we use different procedures in SAS or SPSS or whatever software we're using it. So for example, let's say you're looking to see if there is a relationship between political party affiliation and opinions on the environmental health impact. And we have Democrats, Republicans, and independent responders. And their responses range from agree, indifferent, and to disagree. And we have totals. So each cell has more than 5. We assume that the sample was a random sample, and all these groups are independent from each other, right? Democrat, a person who is assigned into Democrat group cannot be cannot be found in Republican or independent group. So if we do chi-square tests of independence, we can apply it to this data. I will allow you to look at this on your own. There is more information in other slides, and I would like to go to a statistical test, t-test here. It's t-test is applied mostly to continuous data. When we, again, data is randomly sampled from a population, and it's homogeneous with regards to variance, meaning that if we calculate variance in the 2 groups or in the population as a whole and our sample, they will be approximately the same. And we have also assumed that we have normal distribution. So we can use one sample t-test. It's when we have a population and that mean in the population. And we want to compare it to certain value that's already measured. For example, we have a normal blood pressure, right? And we have a data mean blood pressure in the populations that we observe. And we want to see if that mean blood pressure in the population is the same statistically or different from the mean blood pressure in a healthy adult that we have as a standard, right? Or we can do 2 samples t-test, is that we have 2 populations and we want to compare their means with each other and see if their means are similar or different. Let me skip those because we are running out of time. If we have more than one sample, like for example, we have children in grades 1 through 5, right? And we want to compare each grade with each other. Then we will use ANOVA. ANOVA is short for analysis of variance, and it's where we compare 3 or more samples, and we want to compare the means of this sample. We can do one-way ANOVA. It's when, like children, we compare the groups to a certain standard or one of the group, and we can have two-way ANOVA when we compare all possible pairs within those groups. Also, we have regression analysis. This is the most commonly used statistics in public health. It can be either linear regression if we measuring continuous outcomes, for example, age or height, weight, blood pressure. Or we have logistic regression when our outcome is dichotomous or categorized into two values. It can be yes, no. It can be presence of event or absence of event, or it can be like belonging to one of the groups, like males and females. And we compare the results for these two possible outcomes. Now we came to another practice question. This is quite long. I will not read it aloud. We did not go over Spearman correlation test, but correlation test is also applied to continuous variables.
We'll give this 15 more seconds. And 5.
I can see why most of you decided to go for two sample t-test, because you see two groups, right? And two sample t-tests compared to two groups. But let me bring your attention back to the question. So what is our outcome here? If people undergone colorectal screening, so our outcome is either is an event, right? So it's happening, like people did have the screening or they did not have the screening. This is a categorical dichotomous response, right? So we immediately exclude t-test, two sample t-test and correlation test, because this will be a categorical data. And we also see percent here, percent, and when we see percent in two groups, it's most likely that we are measuring frequencies, and when we think of frequencies, we analyze them using chi-square test. And if we go to the next slide, we see that this was the correct answer. Next question. Which test would be best used for comparing the mean ages of participants between two groups? So this one should be easy. I expect 100% correct.
We'll give another 10 seconds on this. And closing the poll.
Almost there. We can definitely apply ANOVA if we have software to do that. It will be just ANOVA between two groups. We can do that. It will give us the same results. The correct answer is two sample t-tests. We have two groups Mean ages, we're comparing two means in between two groups. So definitely out of these four, it's a two sample t-test. Yeah, it's not chi-square because we're talking mean. So we are only comparing two numbers. We're not talking percentages or frequencies. And for those who do not know, Fisher's exact test is a non-parametric test that is used when we have fewer than 30 observations. When our data does not meet normal distribution. Next question.
Give 15 more seconds. And 5.
ANOVA is the correct response here. Again, what brings us here? We have BMI. BMI is a continuous variable, right? And we're comparing means of 4 different groups. So 3 or 4 groups, means comparison, it definitely is ANOVA test. We can definitely apply two sample t-test, but it will be too complicated, not useful. Chi-square test is not applicable because it's not frequency data. Linear regression can be applied. Here we can definitely analyze this data further with a linear regression. What we need for linear regression is a few independent variables thrown in, or one. But here we do not see any risk factors that the researcher would like to bring into consideration, for example, or any interventions. We're just comparing the means. And to just compare the means, ANOVA is the best fitting answer. Another question.
Is that
No,
a
I
different
think it's the
one?
right call. Gillian, I
Yeah.
have a
That was the next question that I had in mind. Did we change the order recently?
I see.
I'm just gonna let them answer this one since it's already started and then
Yeah, let's do that.
sorry about that. We'll give it 10 more seconds. They seem to be doing well at it. 5,
Yes, it's indeed host agent and environment. That's correct answer for that question. And going back to the question on the screen, we are looking at the probability of who will develop type 2 diabetes based on reported data. Yes.
15 more seconds. Five.
Again, I see some confusion going on here. Let's dissect the question a little bit. So our outcome here is type 2 diabetes, right? Probability of who will develop type 2 diabetes. Yes, we see probability. Probability is a range between 0 and 1. So this would give some people, make some people think that this is continuous outcome, but actually the outcome is a yes or no, right? Event or no event, diabetes or no diabetes outcome. And we see some predictors, some independent variables, right? And we are estimating probability which translates into risk. We didn't get to there yet, but risks is what we usually obtain from regression analysis. And when we have dichotomous categorical outcome, like having or not having an event, we apply logistic regression. So returning, we have dichotomous outcome, we have a few predictors. So it definitely will be a regression analysis. Logistic or linear, it's logistic because we have categorical outcome. So we made it through a lot. And now we are going to transition from biostat concepts to epidemiology concepts. So this is the basic epidemiologic triad, the basic what to say, variables that we measure. We have agent, we have host, and we have environment. So we will not stop on this because I'm going to spend a lot of time going through mortality measures, because this is where a lot of people get a lot of confusion. There are very few resources out there that have comprehensive lists of mortality measures. Mortality and morbidity are similar to each other in many ways in terms of formulas. So the only difference is that for mortality, we calculate number of deaths different ways, and for morbidity, we calculate number of diseases in different ways. I hope everybody understands and remembers difference between incidence and prevalence. So we will not dwell on this. But I would like to stop a little bit on this relationship between incidence and prevalence. And I think it's better to look at this picture. So prevalence is how many, like at given certain time or these ways, we have, in certain time, we have a certain population, and among this population, among these people, certain number of people will have a certain disease, let's say hepatitis B. And these people can die or they can cure. So they will go out from this ways. But new people will pour in, new people being people who just got the hepatitis B and are added to the pool. So let's say we have fewer people with new disease. Incidence decrease, but people are living longer with the disease, right? It's a chronic disease, and we got treatment that doesn't cure them, but improves their liver functions, and they can live with this disease longer. So what happens? Naturally, we will have more people, more alive people who have this disease. So the prevalence will increase. If there are more people getting infected with hepatitis, and this is like very severe hepatitis and more people die from it, die sooner. So what happens? This outflow of the people will increase. So we will have fewer people inside with the disease. So the prevalence will decrease. And if the incidence decreases and the duration is short, the prevalence also decreases. So just having this picture in mind, you can carefully predict what will happen with certain changes in incidence, prevalence, and duration of the disease and outcomes of the disease. If more people get cured or more people die, and how soon this will happen. And you can accurately predict what will happen to all the measures using this image. So I find it very useful. There are some frequency measurements that are used in epidemiology, and these are ratios, proportions, and rates. So ratio is when we compare any two values. For example, we can compare prevalence of a disease between males and females, or we calculate days to case ratio. Proportion is when we compare a part of something to the whole, and the numerator is included into the denominator. For example, we have how many patients over a clinic tested positive for syphilis. And it's usually expressed in percent. And rate is a measurement of frequency with which an event occurs in a defined population over a specific period of time. For example, how many new cases of prostate cancer we have for each 1,000 men in the country in a year, in a certain year. And now the slide that you will have to bear with me, because I will go through a lot of different measurements. They are available in the notes. And I just added them just shortly before the presentation. So please make sure you will get this updated slide deck for your reference. So you have all of these measures. Mortality, it's so important that we, in epidemiology, we measure it in all ways possible to find different angles that will provide responses to different research questions and justify budgeting for different interventions. So we start with crude death rate. It's just simply total number of deaths from all the causes for the entire population that we measure. It's usually expressed per 1,000 or per 100,000 people. Then we have cause-specific mortality rate. Is the mortality rate from a specified cause for a population. The numerator is the number of deaths attributed to a specific cause, for example, lung cancer. And then the denominator remains the size of the population at the midpoint of the time period. For example, the number of Atlanta city dwellers in the middle of 2023. It's usually expressed per 1,000 per 100,000 population. For example, in the United States in 2003, a total of 108,000 deaths were attributed to accidents, non-intentional injuries, yielding a cause-specific mortality rate of 37.2 per 100,000 population. Then we have age-specific mortality rate. It's a mortality rate limited to a particular age group. The numerator is the number of deaths in that age group, and the denominator is the number of persons in that age group in the population. And some of these age-specific mortality rates have their own names, so important they are. For example, infant mortality rate is the mortality rate of children who died before they reached 1 year of age. And even that is further separated into neonatal, post-neonatal, early neonatal mortality rates. For example, neonatal mortality rate, it covers deaths that occurred between being born and reaching the age 27 days, up to 28 days. The numerator, therefore, is the number of deaths among children under 28 days of age during a given time period. The denominator is the number of live births that are reported at the same time period. Then we look at maternal mortality rate. Is really not a rate, it's a, strictly talking, it's a ratio that's used to measure mortality associated with pregnancy. The numerator is the number of deaths occurring during a given time period among women who are pregnant or within 42 days of termination of pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. So that's a lot. That's a lot of information to weed out before putting the numerator and denominator together. The denominator is the number of live births reported during the same time period. Maternal mortality rate is usually expressed per 100,000 live births. For example, in 2003, the US maternal mortality rate was 8.9 per 100,000 live births. Then we have sex-specific mortality rate. Is mortality rate among either males or females, and both numerator and denominator are limited to this one sex. We have race-specific mortality rate. The same thing, both the same race goes death and population within the same race group goes into both numerator and denominator. And we have age-adjusted mortality rates. Note it's different from age-specific mortality rate. So age-adjusted mortality rates are allowing us to compare mortality rates between different jurisdictions. Because, for example, state of Utah and state of Georgia can have different distribution of different age groups, while one state may have a more elderly population, while another state may have more children. age-adjusted mortality rates allows us to compare these two states, like make them apple to apple. And there are several ways to adjust or standardize. Another word is age standardized. There are two methods that are applied. I will let you read on your own specifically about how they work. Death to case ratio is the number of deaths attributed to a particular disease during a specified time period divided by the number of new cases of that disease identified during the same time period. It is a ratio, not necessarily a
Dr.
proportion.
Sharapova, we're still seeing the mortality rates slide.
What?
We're still seeing the mortality measurement slide.
Say it again. I didn't get what's.
The slide we're seeing on the screen is still the mortality measurement.
Yes, it's still that. I said that I added these definitions to the notes.
Oh, okay, to
So
the notes, thank you.
Once the participants get the slide deck, they will be able to see the notes. I didn't want to mess up with the number of slides.
Right.
Because of the polling.
Okay, thank
So
you.
all of these are in the
they
notes.
weren't going, so I'll just.
Yeah, we are running short, so let me quickly just read the proportional mortality for you, because this is there will be question about that, and we'll move on. So proportional mortality describes the proportion of deaths in a specified population over a period of time attributable to different causes. So note how it's different from the rate, right? Here we take all the deaths and the percentage of how many of these deaths were attributed to a certain population, certain cause. Whereas for rate, we will take the population and see, like for cause specific, see how many people died from the certain cause of death. So that's the main difference. And we also have important measurement of years of potential life loss. Please pay attention to that. You need to know that. So moving on, we have relative risk. We have attributable risk. Relative risk is a measure of the strength of the association of, between risk factors and an outcome. It's basically saying how many of the people who were at risk got the disease. An attributable risk helps measure the excess risk associated with the risk factor. Excess risk being how many extra cases we have, like additional cases we have due to this risk factor that we are examining. More of that in the tables and how we interpret the risk. So if risk ratio, relative risk, is equaling 1, it means there is no association between exposure and disease. If it's more than 1, like for example 2, we interpret it as that the exposure increased the risk 2 times compared to the risk of those people who were not exposed. And if the relative risk is below 1, it means that the exposure actually protected some of the people from the disease. So it reduced the risk of the disease. If we have RR equals 0.5, it means that half of the people had the disease compared to the population that was not exposed to the factor that we are measuring. So this is a question. And again, we have a little misalignment here. let's answer that question about attributable risk.
Sorry, I was on mute. Did you want to do that data set 11 again? Is that the one?
Yeah, there was a question that was on screen before that about attributable risk of smoking.
This one?
Yeah,
Okay.
because we just covered that. Let's answer it. Yeah, so this question should come with a data table, which will show you different risks. But just looking at the questions in the response options, can you figure out which one will be correct? So people who smoked have a risk of 35, and people who do not smoke have a risk of 18%. Relative.
Another 10 seconds. And 5.
Yeah, so as we just very briefly, I admit, mentioned that during the slide, the attributable risk is an excess or additional risk due to certain factor. So additional gives us, like if we think mathematically, it means like something that was added. So attributable risk is something that should be subtracted. So the correct answer is this, 35 minus 18. That's why I wanted you to answer this question, because I'm afraid that we will have to stop here. There are a lot of slides, like 152 slides total, and we went through 100. I want to leave a little bit of time for answers and questions. I think it will be more important than going through the rest of the slide, which you can do on your own. The questions are there and the correct responses are marked, so you can try them and practice them on your own. And if you have questions, please, how do we do it, Gillian? Will we unmute the person or will they submit questions through the chat?
We would like them to put the questions in the Q&A section, which is right next to chat for them at the bottom of the screen. Or they can ask in chat as well. We monitor both. Okay, the first question we have is, did the domain name change from evidence-based principles to informatics, data, etc., just to be more descriptive? Or was it a change in content as well?
The content did not change. That's just the name.
Great, thank you so much. And the next question is, hello, I have a question. What does mid-interval population mean?
It means we have flexibility and access to enough data to assess the mid-population, the population during the mid-year. It's a point prevalence, point estimate. It means that we have data for the entire year and we just calculate the average and think and measure it like in July over year. So if we have a range of data for different parts of the year, we take the population in the mid-year if we have it. If we have it for the entire year, we just assume that it applies to the mid-year. You know, it's mostly used in surveillance programs.
Great, thank you. The next question is, are the key concepts you would recommend, what are the key concepts you would recommend to focus on when studying?
Everything that was entered into the first few slides mapped to the content outline. I would highly recommend to know by heart and know really well.
Great. And somebody did ask, is there a way to reach out to you directly, or would you like them to go through us, or?
My LinkedIn profile is on the slide, I think, with my contact information, so feel free to connect.
Great.
Or send your questions through Gillian.
Yeah,
And
info@nbphe.org would be how we could reach out. And then I just have a big giant thank you. Not
Thank
much of a question, but I thought I'd mention it anyways. Any more questions does anybody have? Look at that, we're ending a minute early. And yes, we will get the slides out to everybody.
Yeah, I will make sure that I will send the updated slides with all the mortality measures to you, Gillian and Ashley,
Wonderful.
to distribute. Yes.
Oh, there was
Thank you.
there was a, can you show the answer to the question, the slide shown, the relative risk example? Yeah, another question for that one too.
Yeah, so this would be a 2x2 table that was asked to be constructed. So anxiety, no anxiety, coffee, no coffee. And relative risk would be this formula. So this anxiety coffee would be cell A, cell B, cell A, B, C, and D. So you just apply this formula and the relative risk will be 5.
Great. Well, thank you, everybody, for attending today's session. And I hope you'll join us. Our next session is about leadership, and that's on Tuesday, July 30th. Thank you, Dr. Saida, and we will see you next time. Thanks.
Thank you very much. And I apologize that I didn't go through all the slides in my presentation, but I think the rest of them are pretty self-explanatory and you will not have issues reviewing them on your own.
Yeah.
Good luck with the exam.
A good presentation, Dr. Sharapova. Appreciate it. Thanks.
Thank you. Bye.
Bye.